Hello everyone and welcome to a demonstration of how we plan to use the tracker to handle patients in the emergency department. So the idea is to replace the chalkboard that we have with an electronic tracker and using the tracker to pick up, transfer, and inform each other, nurses and doctors, of changes in patient status, just like we use it for labs and X-ray and DI. The first question is, why do we need to do that? It is much more efficient than using a chart rack. It keeps the charts in a centralized location with the nurse at the desk, so there's no more trips back and forth. There's no more charts coming for reassessment and for assessment to be picked up. By automating this process, it makes the data more real time and extraction of data becomes much easier. I'm just going to show you a small audit report here. Take a look at this audit report. So this is a certain patient whose test atoms that on the 24th of April I sent for consultation to the surgeon. And just live as I changed the status to waiting for consult, the timestamp right here is 3:07, and I changed the MRP from myself to Dr. Blewett, one of our surgeons, at 3:08, and that record is there in Meditech forever, and it's very easily extractable, and you can imagine the benefits of that to everything that we do. Is when things get ready, when we reassess patients, when we just make decisions to discharge patients, etc. The other very important benefit of this is that all medical directives will now be implemented to a generic physician called ERP, or emergency room physician, and so their quality control is much easier. And we have built in a QC process into all our new directives as part of this, so charts will not get discharged until all the results are back. Also, it improves your reports getting back to your mailbox. It should eliminate all reports that come to, or almost all reports that come to you for tests and patients you've not ordered. Like what happens right now, because anything you order will go under your name when the patient is yours, and it doesn't go to a different physician. It also has, it improves billing capture by not needing to do stickers anymore. The aim is by the end of your shift, you're able to print out a report of all the patients you saw that day and you signed up for, so you don't have to go around looking around for stickers and keeping sticker lists. And the most important reason why this has become a necessity is that the new ED in the new hospital does not have a centralized location where we can put a chart rack. It is a huge department. The time and effort wasted in moving charts and the ability to lose them is just astonishing. So we have to, before we move to the new hospital, move to an electronic format that does not include moving charts back and forth. So let's look at how we see the process working. The whole process depends on an important fact, which is there are trackers in Meditech, and this is a sample tracker, and what you have is this is our ED tracker. We're all familiar with that. We're also familiar with the waiting room tracker. It shows us the patients in the waiting room. What we have added, and this has actually gone live, all your Meditechs have changed. You will notice a My List tracker, which are actually patient you've signed up for. And here is my list now that is empty. I'm just starting my shift and I'll start picking up patients. You will notice here on the side a few new buttons, the most important of which is a status change. So you can change a patient. Let me go back here. So you can change a patient's status from nurse to see to others. And what we have done is we have here the most common ones that you're going to use, which are you've admitted to CDU, you've consulted the patient, you've brought it back to the nurse to see, the patient is waiting treatment, waiting results, or you've discharged the patient. So it's MD discharge. The flow of patients goes like this. So the patient registers in the emergency room, and he's registered to ERP, emergency room physician. He's not assigned a fictitious name like it's done now. He's just assigned to a doc who probably never sees the patient. And then the patient goes through the tracker, gets assigned a bed, and then what happens is when he's ready to be assessed by the patient, the nurse changes the status to MD to C. And that's how you know that the patients are ready to be seen. So at that point, when the nurse does that, she looks and sees if the patient needs a determined pathway or a directive, and if so, they implement the directives under the ARP. The only exception for these is going to be X-rays. OHIP rules require a radiologist, when they bill, to have the billing number of an ordering physician. So on X-rays in our directives, which are ankles, feet, and chest X-rays and sepsis, are going to have to be assigned to a physician who's on duty, who the nurse thinks is likely going to be the physician seeing the patient. The big issue here is what happens if the patient leaves without being seen. So if the patient should leave without being seen, and this is yes, we've built in a QC process to kick in so that none of these charts are discharged until everything is back. And if there's any abnormal results, then we start a callback form and the patient is called back. If there is nothing, if all the results are back and patient is left assigned to AMA or left without being seen, he's discharged from the tracker only after these results are back. So if in here the patient does not require any medical directives, then he waits until one of us signs up to see the patient.